Okay, thank you. It's wonderful to see so many folks here today, lots of familiar faces. So I'm going to start out by saying that I'm extremely worried about healthcare. I am not sure what it's going to look like over the next several years. There are a lot of competing factors that I think are quite worrisome. And we recognize this, and we want to be ahead of the curve on how care is delivered, not only with us, but throughout the nation. And what I'm going to talk about is the MS, Patient-Centered Specialty Home Project, which I talked about last year, and I'm going to talk about again. But it's a different model of care for patients who have a chronic disease such as MS. And we're taking a page from the primary care folks who have adopted this, but not completely. And so I'm going to tell you what our idea is. And I'm going to tell you a story which I think is very apocryphal. So my dad has multiple medical problems. Okay, I call him. He never gets to answer the phone. It's always my mom. Mom, how's Dad? Oh, all he does is sit in the chair all day. He doesn't get up. My dad's 85. And I hear him in the background go, "Oh, I'm fine. Leave me alone." And so I said, "Get on the phone." So he gets on the phone. He's like, "Pop, how's your blood pressure? How are you feeling? Blah, blah, blah." And he's like, "Oh, I'm fine. Everything's good." And I hear my mom in the background, "Tell him that you can't walk up the steps, that you get short of breath." I'm like, "Oh, my God." I said, "All right, you need to go see your primary care doctor." He goes. I said, "What happened?" She said, "I need some blood work and I need to go see my kidney doctor." Okay. So then a couple days later, I called. "Did you go?" I went. "Did you get blood work?" "Yeah, he gave me some more blood to do also." I said, "Did you do both of them?" "Yeah." Okay. So a week later, which was yesterday, I called. I said, "Did you get your blood work?" And he's like, "Nobody called me." "Well, who's supposed to call you?" "I don't know." And I'm like, okay. And so then I called his primary care physician. He had lost 3/4 of his blood. His hematocrit, which is normally should be 40, was around 11. That's like death. And I'm like, ay. I said nobody was going to call him and tell him what was going on. So last night he was in the ER getting blood. But the point is the fragmentation of healthcare. And it's going to get worse and worse because, as most of you have experienced, if you go see your primary care doctor, it's maybe a 10 or 15-minute visit. And then there's no coordination of care. And so that's what we are looking for in the model we're developing. So on the left is the current model, which, as you can see, is a little chaotic. The brown circles, the patient is the purple circle. They're trying to coordinate their care. It's a mess. And what we want is a patient-centered approach to care where the patient's at the center and there are multiple people that are coordinating the care proactively, not what I did with my dad, which was reactive, but a proactive approach. And the concept, again, this is the cartoon. It's not a real home. It's a virtual home. But as Dr. Shin pointed out, all of the folks that you saw are part of our patient-centered home. Our home consists of almost over 20 people that are involved in patient care. And we are in the process of transforming our workflow. And as one of the things that Dr. Shin just talked about is the ability now to see a patient who needs to be seen the same day. That's an extremely important thing. If somebody has a problem, they can come in the same day or the next day. And so this concept of the patient-centered specialty home, this is just a quote. It's a model of care provided by physician practices that aims at strengthening physician-patient relationship by replacing episodic care. So a half-hour visit with the physician is a disaster. A 15 minutes, even bigger disaster. I was talking to one of my psychiatric colleagues, and they're in a healthcare system. They said they want us to see a psychiatric patient in 15 minutes. I'm like, how's that possible? You can't do that. And there's a psychiatrist here in the audience who may have something to say about this, but it's impossible. And so we want to develop a care team as well as a new approach to what those visits are going to look like. And so a patient-centered specialty practice looks at all of these different aspects, coordinating care with primary care doctors, quality measures that we're going to have, proactively reaching out to at-risk patients. And so we started a process where every Monday we take a look at who's coming in that day or that week. And we kind of identify who is our at-risk patient, who's been going to the emergency room. We need to reach out to them. What can we do to help them out? And there might be other things. So-and-so is coming in for an infusion. Have we reached out to them? And being more proactive. And this is based on joint principles. And you can see everybody on the right is part of a larger team that does the things on the left. So a whole person orientation, coordinated care, quality and safety emphasis is going to be huge, absolutely huge for us. A lot of the drugs that we are using for MS carry a lot of risk with them. And with that, we have to be more vigilant for those problems. And so again, we are trying to change the way we take care of patients. And this was from the American College of Emergency Physicians. And they said the realities of our current dysfunctional healthcare system stand in stark contrast to the goals, the laudable goals of the patient-centered medical home. That's what we want. We want to be that patient-centered home, and we will be the first patient-centered home in the country for multiple sclerosis, and we will get recognition for that in April. And so right now, we are in the process of making that transformation. However, people say, well, that's nice that you're going to do this, but is it really going to change anything? Are patients going to be better? Are we going to change their outcomes? Are they going to be healthier? So to know that, we are actually doing a research study, and many of you are taking part on it. And this is called MS Advance. And earlier this year, you came in, and we may have asked you to do surveys online, which you'll get email reminders periodically to please do a survey. And they're quality of life surveys. And the purpose of that is twofold. One is, as you're doing those quality of life surveys, and not everybody who's here is part of that, but eventually all of you will be part of this. But the idea is that over time, and we have 520 patients that have enrolled in this study. So from January until June, we enrolled 520 patients. Our clinical trial group was extraordinarily busy. All of you signed consents. That was the fastest enrolling MS study ever that's been done. Most studies enroll maybe 400 patients over about 6 years, and we did it in 6 months, and that's all thanks to you all. But those surveys, as we are changing our workflow, you will start to see it, and you're going to say, oh, that's interesting. That I didn't notice that before at Georgetown. They're doing something different. And we think that that will be reflected in your surveys or not, and that's what we're going to learn. And those surveys, as you know, are quality of life surveys. It asks you a lot of things about you, but it also asks you about us and how we're doing. And that is critically important so that we can change. And so the process, as you can see here, is we put together a study. We said we are going to change our workflow. We're going to become a patient-centered specialty home. And then we're going to see if it makes a difference in patient outcomes. And our goal is quality of care, period. This is the bottom line. It's about patient-centered approach to care, that it has to be easy for the patient. That's the critical thing. It cannot be, well, here's 3 pieces of paper like my dad. Go take care of this and let me know when you get it done. No, that time has passed. And the problem with healthcare right now is that we're moving in the opposite direction, where it's becoming more fragmented and more is put on the patient to try to do. If any of you have tried, so my parents, right about this time, it's open season for Medicare. And any of you who have Medicare are probably getting these piles and piles of papers saying, oh, we're having a lunch. If you'd like to come, we have a Medicare Advantage program, or we have this for you, or you might want to sign up with our plan. It's mystifying. And if you think, well, this sounds like a good deal, my parents said, oh, we went to this lunch, and this one insurance company said, oh, if you sign up with us, you will have no copays, you won't need supplemental insurance, we'll take your Medicare premiums, and we'll take care of everything. I said, well, but did they tell you, what's their formulary? What are the drugs that they will allow you to take? Because many of them are restricted. And they said, well, I don't know. They gave us a nice lunch. It must be fine. And I said, no. I said, let me take a look at what you got. And it was a disaster. I said, no, do not change. You know, I got you supplemental insurance. Stay with that. No, that costs you money. Leave it alone. Don't do anything. They make me crazy. And so, but it's mystifying. And that's the kind of thing. What should happen is somebody should be able to reach out to them and say, what medications are you on? And this is the right plan for you, not the other way around. And so that is our goal. And our patient-centered pilot process and analysis, I'm just going to go through some of these slides here. This is a 3-year project. And we are going to be collecting data for the next 3 years. And most of you have already been putting data into the database. And it has been absolutely fascinating. Now, when you put the data in, people say, you know, why am I doing this? Well, you're doing it for 2 purposes. One is it teaches us how we're doing, but over time, you're going to be able to see your outcomes also. And you'll be able to say, oh, you know what? You know, back in November of 2017, I did this survey, and that's what I had. And then fast forward 4 years later, yeah, now I can see a difference. It's going to be your own, if you will, personal diary of how you're doing. But then we can take everybody's information and put it all together and see, you know, what's going on with our MS community. How are they doing? Are we making changes? And so this is some of the things that we've already learned from patient surveys, which are absolutely fascinating. And to have 520 patients that we're gathering data on is an incredible, incredible database. It teaches us a lot about you, but more importantly, it teaches us about the whole community. So at our MS Center, 72% of patients with MS are women, 26% are men. And that's pretty typical of MS throughout the country, that it's 3/4 women, 1/4 men. And the question is, why is that? Well, we know that women have much more risk of having autoimmune disease in general. So that number doesn't surprise us. Our age range was very interesting. We have patients as young as 17 and as up to the age of 83. And actually, that number is not correct because we do have a patient who's 92, but who's not doing the surveys because he doesn't do the internet. And so we said, okay, we can't really have him in the study if he can't do that. Interestingly, the average age of our patients is 49.3. And so that is very interesting. People say MS is a disease of young people. It starts when you're young, but your lifespan is normal. And so what we're seeing is a lot of people who are living with MS who are a little older. And I know the MS Society and Kevin, who's standing in the back there with the blue shirt, they too have found the same data, that a lot of patients with MS, they're not 20s and 30s. We're really dealing with people who are approaching middle age. In our patient population, half of our patients have postgraduate degrees. That's amazing. And that, I've always said this, MS patients are smart. This gene for smart and the gene for MS are right next to each other. It is so true. Nothing against other disease states, but our MS patients are, you know, it's okay. There are other disease states you're like, oh, goodness. But MS patients are very smart. They're very engaged. And the other interesting thing is the most common symptoms that people reported, not surprisingly, are balance issues and weakness of the legs. And that is very typical of MS. In the old days, the old tagline for MS was MS cripples. It's not politically correct, but it's accurate. And then this was the thing that really struck us. 22% of our patients have major depression, not depression, but major depression. And what was interesting, we had a population health scholar who's a medical student who came, and so she spent the summer going into the database. And so she said, so who are these patients that have depression? Is there any way we can identify them? And absolutely fascinating. And we got an epidemiologist somebody who could help us with the statistics. And we said, well, maybe the people who are more depressed are people who are newly diagnosed versus people who had it later, or the other way around. Or maybe it's people who are more disabled, or maybe it's people who have other things. the amazing thing, and this was a poster that she put together, the amazing thing is it had no relation to age. Depression had no relation to how long you have had MS. It can happen whether you're newly diagnosed or whether you've had it for 30 years. Absolutely no correlation with disability. You can be perfectly fine and have major depression. You could be very disabled, and there was no difference between the two groups. Their incidence was the same. There was only one thing that stood out of all of the things that made a difference, and this is not a big surprise. If you made more than $100,000 a year, you were less likely to be depressed than the people who made less than $15,000 a year. And so we wanted to title the poster, "Money Can Buy You Happiness," but that was not going to fly. And there's many things. And so she presented this poster, and this was, her name was Erica Menino, and this was all of us who were there for the presentation, because even though she collected the information and analyzed it, all of the data comes from you all. And so you should all be very proud that this was presented there. And I do want to point out a few people. I know I have 2 minutes to go here, but I do want to point out some of the people who are standing here. So first of all, Susan Stewart, if you want to just stand up. So Susan is our nurse director of the Patient-Centered Specialty Home. And Sonia, where's Sonia? So Sonia, all right, well, we'll get her. Lexi can stand up. Lexi is our Director of Clinical Studies and who helped really structure this. Nancy, who is not here, she's our MS Fellow, who some of you have met, and she's terrific. And then Sophia is she there, Sophia? And so Sophia is part of the patient-centered practice as well. Did I leave anybody out? And so they're really the core group that are driving the changes within the center to become a patient-centered practice. And this has gotten national attention. This is from our trade magazine, the American Academy of Neurology puts out, and they heard about what we're doing and recognized the power of taking a patient-centered approach to care. Now, you can see that the piece on me is about a quarter of the page. 3/4 of the page is for a migraine medication. This kind of shows you what value they put, but anywho, that's the way it is. And Dr. Shin has already shown this picture because everybody here has been crucial in getting this off the ground for us. So next year, when hopefully we do this again, I can give you even more insight into the data that we're gathering. Are things changing? Are the big things we're looking for? Do we have fewer hospitalizations? Do we have fewer ER visits? One of the things that we've learned from our survey already is we need a mental health counselor in our group when we have so many patients who have major depression. So we've learned that we're going to have to do that. We also have learned that we need to take a wellness approach to health. And so already your surveys are going to change what we're going to do. We are going to develop a wellness center at the MS Center over the next couple of years. And I want to make a plug for the Be Here Now Yoga group, who is out the door and to the left. I don't think Christine is in here. I think she's still out at the desk. So that's my yoga studio. That's where I go, and that's where I took 200 hours of yoga teacher training, and they're totally awesome. And I would encourage you to talk to her. It's up on Capitol Hill, may not be, but we are developing strategies with her, with the MS for Movement group, who are also out there, Kira, with our physical therapy group. I know Lisa Ebb is here. Dr. Jones is going to help us with mindfulness-based stress reduction. And so we have a whole new approach that we want to take towards care that your surveys have informed us that we need to do. And as we go along, they will continue to change and we'll adapt to that. So I'm going to stop here. I'm right on time. And so that way the next speaker can come up. I think we're going to have a panel discussion for questions later.